Okay, so we're starting with the first clinical scenario, cardiothoracic clinical scenario.
Yes,
You
sir.
have a 26-year-old gentleman
Yes,
who
sir.
has presented to emergency department with shortness of breath.
Okay.
He is he is an asthmatic who has previously been admitted with status asthmaticus or worsening of asthma
Okay.
and has required treatment in the past. On the other side of the story is he is a very professional bodybuilder and he uses very heavy doses of steroids for his bodybuilding work.
Okay.
So he had an episode of syncope while he
Okay.
was at the gym, and then started having shortness of breath, and he's struggling with catching his breath, and he's been admitted to emergency department.
Okay, sir.
So you can start describing that.
I'll, I'll summarize the scenario, Dr. Danish. I have in front of me a 26-year-old man with sudden onset shortness of breath, and he's a known case of asthma and a steroid abuser as well. Now, his presenting complaint is shortness of breath and a history of syncope. So now I'm seeing this patient in the emergency department. My first line of management would be to approach him with the ABC approach. I'll make sure that the patient on presentation is having a patent airway. I would administer him supplemental oxygen to support his breathing. And as far as circulation is concerned, I would make sure that I would take 2 whiteboard IV cannulas and start him on fluids, and if required, on vasopressors as well. So once his airway breathing system is stabilized, I would have a look at his GCS, and then I would examine his other systems as well. In the meantime, I would take a short history from him regarding his shortness of breath, as to for how long it has been, and as you already mentioned, he's a known case of asthmatic. So how often does his exacerbations happen, and how many hospital admissions he's had in the past before, and as to what sort of treatment he is on for this asthma in particular. And now one more problem which is bothering me is his syncope, which he has suffered from now. So again, there are a few things that would come up to my mind as far as his syncope is concerned. Most commonly, syncope would be pointing towards cardiac cause. So I would try to rule out whether the patient is having any cardiac problems or not. So I would ask him history regarding failure, history regarding any previous history of syncopes or blackouts in the past. And I would try to make a conclusion with this. And once my history is done, I would go with examining the patient. My prime examination in here would be the respiratory system and the cardiovascular system. I would be in the respiratory system looking for any added sounds. I would expect him to have wheezing if this is again an acute exacerbation of asthma. And as far as cardiovascular system is concerned, I can expect some added sounds such as murmurs or grunts, which could suggest any valvular heart diseases or failure. And from there, I would liaise with a cardiologist to go in for further investigations, which would be general investigations such as hemoglobin, WBC, platelets, electrolytes, and specific investigations such as pulmonary function tests and echocardiography for his breathlessness.
I mean, from the cardiology point of view,
So
before progressing to echocardiography, would you do any other basic cardiac test?
I would do a 12 lead ECG, sir. I would do a 12 lead ECG and an X-ray as well to have a look at his heart.
So you've done a 12 lead ECG, and this is how it looks.
Okay. I would like to report this ECG, sir.
Yeah.
I have a 12 lead ECG in front of me. It seems to be of good quality. I would start with the rate. The rate is approximately 60 beats per minute, and the rhythm is regular, and it seems to be sinus. And
Yeah.
now I'm going to the axis. I think the axis is normal as far as the lead 1 and lead 3 is concerned. And next, now I'm going for the individual waves. I'm looking at the P wave in lead V2, and I see no abnormality. The P wave looks normal to me. And the QRS complexes are not wide. They are also normal to me. And as far as the T waves are concerned, there is no T wave flattening or inversion. So that looks normal as well. Now, as far as the intervals are concerned, My first thing would be the PR interval. PR interval is also not prolonged. And next would be my QT interval, which is absolutely normal. And as far as the ST segment is there, I don't see any significant ST segment elevation, but for in lead V1, where I have a little bit of ST segment elevation. And other than this, I think there is the QRS complexes are quite tall in lead V4, V5, and V6. This may suggest left ventricular hypertrophy.
Okay.
Now, there's a bit of Q wave in V6 as well, which I can
Yeah.
see.
Yeah.
So, so my provisional diagnosis with this ECG would be a left ventricular hypertrophy with an old MI, but I would correlate this clinically, and I would do further investigations before I come to a diagnosis, sir.
Okay. So once you've thought about left ventricular hypertrophy,
So,
what next investigation would you like to do?
okay. Once a combination of left ventricular hypertrophy with a history of syncope, I have certain things in my mind. My first diagnosis would be a pressure overloaded left ventricle, which could have caused the syncope, which most commonly due to a valvular lesion of the aortic valve, possibly aortic stenosis. So I would correlate this with an echocardiographic evaluation as well to have a look at
Okay.
the aortic valve.
Here's your echocardiographic evaluation.
I have a 2D
This
echo in
is,
front of me.
yeah,
This is a parasternal long axis view, if I'm not mistaken.
that's right. Yes.
So I can see the left atrium, I can see the left ventricle. I can see a very hypertrophied thick wall of the left ventricle. And as far as the outflow tract is concerned, there is the aortic valve. I think this would suggest a hypertrophied left ventricle. So because the thickness of the one thing, let me annotate it 1 second. Annotate, draw. This one, it's like quite thickened ventricle, if I'm not mistaken. So
Yeah. Yeah.
this could possibly suggest left ventricular hypertrophy, and with echocardiography and further evaluation of the valve, I can
And
maybe
this
rule
as
out
well.
diagnosis.
Yeah.
Interventricular system is also thickened, so the effective volume of the left ventricle is reduced. This could possibly be a pressure hypertrophy on the left ventricle, which is causing
So,
hypertrophy.
so what is wrong with this patient?
A hypertrophied left ventricle is having a diastolic dysfunction because the effective end diastolic volume is reduced. And on top of this, the increased muscle mass of the heart is also increasing the demand of his oxygen. So there is basically myocardial supply demand imbalance in this patient.
Yes.
That could have possibly led to syncope.
So what condition do you think if you were to give a differential diagnosis for this?
I can think of two, sir. If the aortic valve is normal, then I could think of hypertrophic obstructive cardiomyopathy. If there is an aortic valve pathology, this could possibly be a left ventricular hypertrophy secondary to aortic stenosis or hypertension, chronic hypertension.
So the history that he has given you, it doesn't involve any hypertension. And if you go back to the history, what is that aspect of the history that flags up?
Okay, I think chronic use of anabolic steroids can have an impact on him developing hypertrophic obstructive cardiomyopathy, sir.
Yeah, steroid induced. So, what are the other causes of hypertrophic cardiomyopathy?
I can classify this into congenital and acquired. Congenital would be genetic causes, congenital hypertrophic cardiomyopathy. And acquired causes would be, as we mentioned in this case, steroid abuse. And I'm sorry, sir, I'm unable to recollect.
No problem, sir. What are the acquired? You mentioned about primary cardiomyopathy and secondary cardiomyopathy, as it's called. So you mentioned about the acquired ones. What are the kinds of Other cardiomyopathies that are primary, other than congenital. Pregnancy related?
Yes, sir. Pregnancy
Yeah,
related
yeah,
cardiomyopathy there.
yeah, yeah.
And
And there can be others, can be mixed, which is dilated or restrictive cardiomyopathy.
okay.
Now, yeah.
Yes.
Now, tell me about the secondary cardiomyopathies. What are the causes of secondary cardiomyopathy? One of them you just mentioned, or any other?
As I mentioned, aortic stenosis is one, and chronic hypertension can lead to left ventricular hypertrophy. That
Yeah,
is another cause. And,
yes.
any
Any
other
metabolic?
metabolic would be diabetes. No, sir, I can't.
Amyloidosis, hemochromatosis. Yeah, yeah,
Amyloidosis, sarcoidosis, they
yeah,
can all cause hypertrophic cardiomyopathy.
yeah.
And
Any
yes,
infection related?
um, I'm sorry, sir, I'm unable to recollect.
Viral myocarditis. Yeah, viral myocarditis. Ischemia related to ischemia, related to coronary artery disease. Then you
Okay.
could have, other glycogen storage disease related cardiomyopathy, lysosomal damage related cardiomyopathies. As you said, aortic stenosis or mitral valve insufficiency
Yes, sir.
related. Okay. Now, what are the, you mentioned about the supply and demand. How does it get severely affected in this case? And how
Uh,
does the cardiac function get affected? If you just tell me the dynamics of.
yes, sir. First one is, as I already mentioned, there is a myocardial supply demand imbalance. A patient with hypertrophic obstructive cardiomyopathy, even at rest, his heart will be requiring more oxygen than normal. So the demand will be high, so supply has to meet it adequately. Now, this patient, imagine he is coming to the operation theater and he is put into a sympathetic stress, say, for example, intubation or a surgical incision. The pulse rate, the heart rate will be increasing. The time for diastole is reduced, so coronary perfusion is reduced. So this, in combination with the hypertrophic muscle, would further cause a mismatch in the demand and supply. So that would put the patient at high risk of ischemia. So it is very imperative to maintain sinus rhythm and a heart rate of about 60 to 80 with adequate preload and good oxygenation to make sure that this patient is having an adequately perfused myocardium. And other than this, hypertrophic obstructive cardiomyopathy patients, there's one more mechanism that is involved, which is called systolic anterior motion of the mitral valve, which would be causing the left ventricular outflow obstruction. So in order to prevent this, again, I think advanced monitoring methods such as transesophageal echo would be helpful, which would give us a direct visualization whether the left ventricular outflow tract is being blocked or not. So these
Okay,
two things pop up to my mind, sir, in a patient with
that's
HOCM.
that's good. That's good. And what are the treatments that you would do intraoperatively for these patients?
Intraoperatively, yes, sir. I have
Or,
certain
or, or, or for example, you take this patient to ICU. How will you manage this patient?
okay. In ICU, as I already mentioned, first my target would be airway, breathing, and circulation. And
Yeah,
my primary target is to maintain adequate hemodynamics in this patient. So apart from other standard monitors such as ECG, NIBP, and pulse ox, I would install invasive BP line for this patient. And as far as my management is concerned, maintain a sinus rhythm with a pulse rate of about 60 to 80 beats per minute and give him a good preload, maintain the fluid status, maintain contractility is not an issue in here. And as far as afterload is concerned, I would prevent any losses in afterload. I should maintain a good afterload because a loss in afterload would again cause the systolic anterior motion of the mitral valve. And the other thing is a loss in afterload would reduce the diastolic BP, effectively reducing the coronary perfusion pressure as well.
this
And
pa-
other
patient this patient has given you history of syncope or syncope. What could have caused that syncope?
a reduced cardiac output because of diastolic dysfunction is the first thing that comes into my mind in here. So it's basically diastolic dysfunction because the ventricular volume is reduced and effective ejection fraction is also, stroke volume is also reduced in these patients.
What
And
could have caused, other than the mechanics, what could have caused a transient decrease in the reduction in the cardiac output?
As far as the history was concerned, he was exercising at the time of this attack. So the patient who is exercising will be having an increased demand of oxygen. So that would have caused tachycardia and it would have precipitated his syncope. So in ICU also, I would make sure that I provide this patient with good analgesia and good PONV prophylaxis so that no tachycardia is happening in this patient. No other causes of tachycardia is there.
Why do patients with hypertrophic cardiomyopathy or cardiomyopathies in general, what are the other causes of syncope in them other than this reduced cardiac output because of mechanical causes?
Um,
Any rhythm changes that you're aware of?
uh,
So
Conductive can be damaged, so they can go into I think bradyarrhythmia, sir, which would possibly cause reduced perfusion to the brain, causing syncope.
ill-sustained VTs.
Okay.
Okay. Okay. So your treatment now, would you consider intubating this patient, or would you manage this patient as he is?
That would depend, sir. If he is, there are pros and cons for both. The advantage of giving adequate oxygenation to this patient to meet his demand should be weighed against the risk of sympathetic stimulation that would accompany him during intubation. So I think if the patient is maintaining a patent airway with adequate oxygenation, I don't see any need for intubation at this point, sir. But if he collapses respiratory wise, then I would not hesitate to intubate him and put him on ventilator.
So collapsing just respiratory wise, or any or
Even
cardiovascular?
collapse, yes, sir. Even cardiovascular collapse as well. I would consider intubating him.
So you have, yeah, you'd wait
I would
for?
weigh the benefits and risks before intubating him. Yes, sir.
Okay. So you you have decreased the ventricular contractility in this patient to reduce the oxygen demand, right? This patient, on the contrary, was getting hypertensive. Okay. Now, but at the same time, this patient was quite hypovolemic. He had a significant good session of exercise. He had drained himself and hadn't really replenished himself, so he was hypovolemic. So you replenished the volume. We checked on the echo; it showed quite empty ventricles. And what else would you do to prevent arrhythmias in this patient? Or sympathetic overdrive?
Yes, sir. I can think of giving him some sympatholytic drugs such as beta blockers. Would put him on a short-acting beta blocker such as an esmolol infusion to maintain sinus rhythm and heart rate of about 60 to 80 per minute. And then this, in view of improving his coronary perfusion, I can think of vasodilators such as nitroglycerin to increase his perfusion. And you already mentioned the patient is having hypertension. So I think esmolol and glycerin trinitrate will come in handy in this scenario, sir.
Would you include a calcium channel blocker when you're using esmolol?
No, sir. I think a combination of beta blockers and a calcium channel blocker can dangerously reduce the contractility and precipitate heart failure. So it should either be one of the above, but not both together.
So now this patient is reasonably stable in ICU. He's awake, but he is on a combination of drugs to maintain his cardiac functions. His cardiac functions have significantly diminished. So what is the way forward from here?
Liaison with a cardiologist to help me out in the management of this patient.
So they've said that we have provided him the maximum medical management.
I can think of a surgical management for this condition, sir. It would be, I think, septoplasty, where they would scrape off a part of the ventricular wall in order to effectively increase the volume. I'm not sure of the procedure's name, but
Yeah.
I've heard about this surgical management of hypertrophic obstructive cardiomyopathy.
Yeah.
Or
they can do myectomies. They can do
exactly, that's what
septal ablation as well.
Okay.
Septal ablation is the other option.
Okay, sir.
I think your image has frozen. Give me 2 seconds. Can you hear me?
Yes, sir, I can, but your video is frozen. I still can hear you. Now you're back.
Can you?
Yeah, you're back. You're back.
Yes. So now with his recurrent VTs, which was giving him syncope, and during his ICU stay as well, he had few runs of VTs, ill-sustained, but there were VTs which were dropping his blood pressure. Okay. So what will be? How will you safely discharge him from the hospital?
Yes, sir. I can think of medical and interventional management for his condition. If the VTs are not so malignant, again, after liaison with cardiologist, I can give him tablets of amiodarone during his discharge, or if it is very significant, I can liaise with the cardiologist to put him on pacemaker. Yeah. For him, permanent pacemaker, sir.
And if it's a very, very severe cardiomyopathy, what is the final resort? With the ejection fraction being 10 to 15%, what will be the final resort?
If a suitable donor is present, then probably heart transplant.
Transplant, yeah. So, okay. Let's see where we are in terms of time. Oh, only 20 minutes. Okay, so let's just share some images. So you guys can have a little bit of. Are you familiar with the transthoracic echocardiography? Views of
transthoracic to some extent, sir. To some extent.
So let's start with this view. This initial cut sections.
Okay.
Can you see that?
Yes, sir. We can.
Yeah. So you can see the long axis view, parasternal long axis view. Yes. That is this view here, right?
Okay. Yes, sir.
And you have the short axis view here, right?
Okay.
And you can see that what the image given by the parasternal long axis view is the image here. I'll give you a better image shortly. Short axis view image is here, as you can see that. Yeah. So yes. Just to give an idea that if you put the probe across the heart and across the short axis of the heart, this is the image you will get. And if you put it along the long axis, the top left image is what you will get. Let's just share. Okay, so this is the short axis view. Yeah.
Yes, sir.
And you can see the things highlighted here. I'm not sure whether they will give you transthoracic echo images, but just for your sort of initial basic understanding, so you don't get caught out there, I'll just put these images up. So they wouldn't ask you about to show you the coronaries or tricuspid valve. As long as you know about the chambers, which is left, which is right, yeah.
Yes, sir.
And which is ventricle and which is atrium, that should suffice. So just a few more images of the. Okay, let's start with this first. Okay. This is a very basic image. It's again start with the short axis view on the top left here. Yeah, which we just saw.
Is this short axis view, sir?
No, sorry. This is a apical four chamber view. This is an apical four chamber view. My apologies.
Yes,
yeah. This is the long axis view.
Okay.
Which we were talking about. And you can see there is this aortic left aortic outflow. This is the left ventricle. This is the right ventricle, right?
Yes,
As
sir.
you can also see. Oops, sorry. Oops. Yeah, it's a slightly better view here. Does that make sense?
It does, sir. It does.
Yeah, yeah. So let's go to the apical view. So you place the probe at the apex and beam it towards the beam it towards the heart, and you see what is on the right here is the left. So this is the left, and this is the right side. So this is the left ventricle. That's the right ventricle. Left atrium, right atrium. Yeah.
Okay, sir.
Does that make sense?
Yes, it does. It does, sir.
Yeah. It's just that it's a heart, but inverted because it has been beamed from underneath. Oops. Then that's another. I don't think you'll need a single chamber view. That is the
Short axis view.
Yeah, short axis view here. So you cut across at the level of, this looks like the mitral level of the mitral valve, I think. Let me check. I'm not 100% sure. Let me. This is again another view of the long axis. Yeah. 4-chamber view, which we had just discussed. You have placed the probe at the apex, the top. I mean, at the bottom of the heart, and you're beaming it. Papillary muscles. Which one was papillary muscle, Nitin?
That before you showed, na, you were talking about that mitral valve. It is papillary muscle view, short axis. Yeah, this last one in the corner.
This one.
Below.
Okay,
Yeah.
okay.
The papillary muscles view.
Sure. I have not followed up on my echocardiography course. I did it maybe 5-6 years ago, but I've not done many echoes in ICU. So my understanding is very, very sort of basic about these views. I'm sure you do them a lot more often. In theater as well, it's catching up, but ICU is the main place to learn about. We call it a FICE course here, where you have these 4 views. So I think basic. This is the short axis view, which is a long axis view, which is very common, and we just discussed about the dilated left ventricle and the interventricular septum. Again, this is hypertrophic cardiomyopathy, where you can see the left ventricle is quite severely dilated. So not dilated, hypertrophied. Yeah. So I think these are some of the views for just if these scans show up in the exam.
Yes, sir.
Yeah.
Yes, sir.
So I think that sort of mainly summarizes. In ECG, you wouldn't find anything more significant than the left ventricular hypertrophy, deep narrow Q waves that are possible, and yeah, that is the differential diagnosis. Based on left ventricular hypertrophy, you were right. It could be aortic valve stenosis, mitral valve insufficiency, and you mentioned about the primary cardiomyopathies and secondary cardiomyopathies, which we discussed. That's really it. Actually, it's management is pretty straightforward. The main treatment goals are decreasing ventricular contractility to reduce oxygen demand. You increase ventricular volume because it's according to the Starling law, if it's not if there isn't enough volume, it won't contract that much. You increasing left ventricular compliance and left ventricular outflow dimensions. Vasoconstriction, that is another thing in prevention of arrhythmias. You do not want any reduction in the ventricular filling or in the coronary filling as well. Medical therapy, beta blockers or calcium channel blockers, diuretics, amiodarone, all these are options there. You could go for, depending on whether it's a hypertrophic cardiomyopathy or obstructive cardiomyopathy, you treat accordingly and plan the surgery accordingly. Internal cardio defibrillators, ICD devices, dual chamber pacemakers. All these options are available. Septal ablation is the other aspect in this particular case, and heart transplant is the final option that you would consider. Yeah.
Yes, doctor.
So I think you picked it up very early. Now imagine in this situation, the history was of an asthmatic presenting with shortness of breath. It's quite misleading, isn't it? The person who has is got working out in a gym, having syncope was probably the only giveaway. Steroids meant, sorry?
No, sir. I think the syncope was the only thing which pointed me towards the cardiovascular factor. Otherwise, it could have gone towards exercise-induced asthma as well.
Yeah. Or sepsis. Chest infection and patient developing sepsis and coming in. And normally, if you had rushed to intubate this patient, I would have taken it towards respiratory failure. I would have let you do the intubation and sort of follow that drill. And then I would have said to you that despite being on 100% oxygen, despite doing this, his blood pressure is still not coming up. And what is the cause? And then you would have come to, you could have wasted some time before you could have come to this point. So that is something you have to explore. And one very quick, tip in your practical observation as well. If there is an asthmatic who has had repeated asthma admissions, the only thing you ask that person is, does this feel like your typical asthma attack? And he will straight away say, no, it's not. I mean, auscultating and all that will definitely give you a more depth picture. But if you ask him, he will straight away say, no, it doesn't feel, the breathlessness is not the same. Yeah.
Yes.
This is from my own personal experience. I've had a patient with cardiomyopathy, known asthmatic. This is a case that I did myself actually. So I have put it as a for your learning. Young 26-year-old, very active in gym, use excessive amount of steroids, and has had previous ICU admissions with asthma. And this time, we thought he's got chest infection and brought him in on BiPAP, and he wasn't responding. And then one of the professors in anesthesia, he just asked a simple question to this patient: does this seem like your typical asthma attack? And he said, no, it's not. Straight away, the image is got a echo done, and it revealed that he had a cardiomyopathy. So, okay, so let's continue the second part. Who would like to come up, guys, amongst you?
Thank you, Dr. Danish. I'll mute myself. Thank you.
Yeah, thank you, Naveen. Thank you. Will I be seeing you before your exam next week? I mean, on 23rd?
Yes, Dr. Danish. It's on 27th of March. So probably on 19th and 21st, I'll be appearing, but not on 26th. I think probably the day before the exam is not right. Or maybe I can just attend, but not volunteer. That will be a different mindset for me at that time.
True. Yeah, just go through whatever reading is done. Sometimes you don't want to immerse yourself in all that. You want to take a step back.
So probably if I give a try and that doesn't go well, then that would not help with my mood either. Probably I'll be a bystander watching all the scenarios which you discussed with others.
You've done your preparation is good. Don't have to worry about it at all. So,
Yes.
but yeah, it depends on the day actually. As you know.
Yes, yes. Thank you, Dr. Danish.
Ask a couple of questions, maybe this one.
Yeah, go for it. Yeah, go for it.
We are talking about cardiothoracic
Yeah. The first one was on the hypertrophic cardiomyopathy.
Okay, that's fine. I will probably move away from that. Can you tell me what monitoring do you need for cardiac surgery?
So,
for example, CABG surgery.
CABG. All right. I would classify as non-invasive, minimal invasive, and invasive. Depends of the patient frailty.
No,
Definitely.
no. I mean, my question is, what monitoring do you need for cardiac surgery?
Okay,
right?
so yeah, right. So definitely an invasive arterial line for a blood pressure monitoring. I would place a central line to monitor the CVP. A sheet if the patient is quite frail and if it's high risk for and just place the sheet for a query Schwanzgang catheter for later on plus minus. Obviously, a saturation to monitor the saturation, the arterial peripheral oxygen saturation of hemoglobin, heart rate, urinary output, temperature, and depends. If you are using the TIVA, TCI, I would place a BIS or entropy monitoring. CO2, entitled CO2 as well, yeah, this is overall the monitoring I would go for.
Is there anything else that you would consider using?
Respiratory rate, definitely, but this is the rate we set by the ventilator. I told about temperature. I missed something. I'm not sure. Urinary output I already mentioned, and definitely yeah. Serial ABGs, ACT, a tag if I'm getting into troubles, and pre-surgical test and laboratory labs figures like usual.
Do you mention temperature to me?
Yeah.
What temperature would you monitor for a cardiac surgery?
If he's going the central temperature, an intrarectal probe, for example, might be an option, because the patient usually on the CBP on the pump they are getting hypothermic towards 26, and the recovery, the rewarming should be controlled in order to give the start to come on off the CBP, the pump.
Okay. Any other monitoring that you would think of here, specific to cardiac surgery?
Monitoring.
What about TOE?
Yeah. Oh, yeah. This is a test. Yeah. Obviously, TOE is paramount. Yeah, and TOE skills, especially in cardiac patients, this is a requirement. Yeah.
Okay.
Not so often in cabbages, but in valvular, this is mandatory.
Yeah. So in terms of monitoring, general monitoring, have you missed something?
In terms of monitoring,
Yes.
blood pressure might be
So you told me pulse oximetry, you told me invasive blood pressure, you told me CO2 monitoring, you said temperature, PA sheaths, you said you would consider PA catheter, that can tell you a lot of things. Did you tell me ECG?
I told about heart rate, obviously included the ECG, but not purposely ECG.
Yeah.
And and definitely if we are using gases, inhalational.
Yes.
Gases,
So whenever you talk about anesthesia, do not miss your basic monitoring. And basic monitoring is pulse oximetry, ECG, non-invasive blood pressure or invasive, depending on what surgery you're doing. So after that, CO2 and tidal CO2. And then you're looking at the gases monitoring, which involves inhalational and exhalational O2 monitoring, and and the agents that you're using, right?
Yeah.
And tidal agent concentration. So, and then you're talking about transesophageal echo monitoring in this particular case, but monitoring, temperature-wise, you're talking about peripheral temperature, you're talking about nasopharyngeal temperature, and you're talking about myocardial temperature. So if you say these three temperatures, it will make a huge difference than just saying temperature, because here sometimes myocardial temperature does matter. Okay.
Yeah.
Then we talk about
sometimes
cardiac.
Can I add? Sometimes we are using, if you're using aneurysms repair, we might use the near infrared cerebral how to call saturation is like
CMRO2. That is cerebral metabolic rate of I think that's what it is.
Kind of.
So, yeah, the thing is, what you need to know is don't miss your basic monitoring. Then think of what additional you will require for this surgery or any other surgery. In this case, it's cardiac. So why don't you think about temperature specific to cardiac output monitoring? And in this case, cardiac output plus, which gives you much more information, is TOE.
Yeah.
Right. Now, can you tell me what are the benefits of using TOE in cardiac surgery?
TOE, it's we definitely using the TOE. We should have a figure, an assessment before the surgical intervention to rely on to see to see what is the status of the valve, of the contraction, and obviously after coming off after the surgery. Gives you an idea about the contractility, the valve patency, the gradient, the pressure gradient, the volemic conditioning, the volemic.
Okay, we'll come to that in a minute. Tell me what are the problems and what are the problems with TOE? What problems can TOE cause?
Risks of the TOE. You're right.
Yeah, you mentioned risks. Yes.
Yeah, that's it. The placement. The main risk is esophageal perforation, or gastric perforation if you're using a transgastric view. Sometimes the temperature, if we are using longer time with the temperature, is a minor risk, but is described as a temperature-related the thermistor risk for increasing perforation, bleeding, also. Perforation, esophageal perforation and gastric perforation, the main ones.
Any other things that come to your mind with echo?
Breathing disturbances can due to misplacement can be rarely, but this can be described. Placing into the trachea, if it's very rare, but that can be just assuming, just presuming.
So, what advantages does TOE give you? What are the advantages of using TOE? What does it tell you?
So, the overall contraction of the heart, valvular functioning, also gives you an idea how much the ventricles are filled or not. Gives you idea about the thrombus in the heart, for example, in the sinus. Gives you an idea of not a specific target for coronary. It's not the main, but you can see sometimes the coronary the vessels. Pericardial effusion, tamponade. Pictures also can give you idea about the structural modifications, like the heart hypertrophic dilatation of the heart, the ventricles movement. Yeah, these are the main ones.
Okay, while you're doing a cardiac surgery, what are the important points in a cardiac bypass surgery when you have to be careful as an anesthetist?
So when you come off the bypass, you need to assess how good is the ventricles volemic volemia of the ventricle, in order to bring more blood from the bypass. You need to see the contraction, how it is, the contraction, if it's contracting well. If not, you can top up some more chronotropics or inotropic drugs like milrinone. Also, you can see the flow through the valves, leakage of the new valves, contraction, overall contraction of the heart, of the muscle, if it's akinesia or dyskinesia.
No, my question is, what are the important points in a cardiac bypass surgery, while you have to be alert as an anesthetist? You said coming off bypass, yes, that is important event. Any other important events through the surgery?
The valvular, the function, the overall function of the heart, the new valve functioning well, aeration or deaeration is a point. You can help the surgeons with the picture of the TOE.
Okay, that's fine. What does ACT do?
Anticoagulation time. It's the time we monitor.
Anticoagulation, are you sure?
Anticoagulation time, ACT.
Okay, what's it used for?
Is to monitor the heparin activity. Mm-hmm. It's monitor the heparin efficiency, and it's a time we rely on putting the patient on the bypass, because should be anything above, depends on the center, 420 seconds or 480 seconds, according to the lecture we've got yesterday.
Okay, yeah, let's stop here. I mean, you've done well. This is not an area that will be asked in the exam, I guess, too much. It's but what will be if they do ask you such questions, or say something comes up from cardiothoracic anesthesia, which shouldn't be really asked in IDAC in detail, but what they would expect you to say is, do not miss your general anesthesia knowledge, basic monitoring. You should all remember that basic monitoring includes ECG, non-invasive blood pressure at least, number 3, pulse oximetry, number 4, end-tidal CO2, Number 5, inhalational gas monitoring. Number 6, oxygen monitoring. Number 7, neuromuscular monitoring if you're using muscle relaxants. Okay, so even if you haven't asked any big surgery or anything, if you say these 7 points, you'll basically pass in the exam because you are expected to know this. Beyond this, whatever you say is a bonus and you'll gain more marks. But explain, because normally we just would mention non-invasive blood pressure, CO2, pulse oximetry, and ECG, but that's not all. Remember, gas monitoring is important and you should mention all the gases. And if the surgery is more than 30 minutes, say that if the surgery is more than 30 minutes, then I will also involve temperature monitoring.
Right.
So that's another thing to add on. And if the patient has got any issues with, sorry, glucose metabolism, then glucose monitoring as well, right? So add these 3 and 4 extra things, or maybe 5, 6 extra things that bring value to your Viva, and that makes a good impression before the examiner. So make a list of these things as your basic monitoring. And then beyond that, it depends upon what case you're doing. For example, in cardiac bypass surgery, you will be monitoring extra temperature like myocardial temperature, peripheral temperature, nasopharyngeal temperature. You can monitor activated clotting time, ACT, right? You can do that. And then you are thinking about cardiac output monitoring, whether most likely an transesophageal echocardiography, right? So that's very relevant in terms of cardiac bypass surgery. Then ABGs you mentioned, etc., etc. Hemoglobin monitoring would be good that you can add on to that case. The problems with TOE is important. I think if you're asked, you can add the same problems with TOE, same problems with Doppler, esophageal Doppler. You can put similar problems with NG tube. And you can also put similar problems with something else, which I can't remember right now. So the problems are injuries, number 1, right? You classify them into injuries and others.
Yeah.
In injuries, you start from, do not say only gastric injury, you start from mouth, right? Start from teeth. You can
They're right. Yeah.
You start from lips. You can cut the lips. You can break the teeth. Then you can cause oropharyngeal laceration and perforation, right? You come down, you go into laryngeal area. You can cause vocal cord trauma if the probe goes into the wrong side, right? You can cause tracheal intubation of the esophageal probe, the TOE probe, right? So that is a complication that can happen. Then if it goes into laryngeal area, it can induce a laryngospasm, and the percentage rate of causing laryngospasm with TOE is 0.14%. So it's significant in a way.
Yeah.
It is not unknown. And then you go beyond larynx, you go into esophagus. There you can cause laceration, perforation, or you can cause a creation of a false passage in esophagus, which is called as creation of a diverticulum, right? You can cause that. And then you reach lastly gastric and the stomach, where you can cause, again, laceration, perforation, or bleeding, or you can cause bleeding throughout all these areas. But the other things that you can cause is laryngospasm, as we mentioned. You can cause bronchospasm, and you can cause tracheal intubation and hoarseness of voice because of this. It can also sometimes lead to endotracheal tube malposition, right? Which is about 0.2%, right? It's not unknown. So remember, the key thing to know is you start from lips, go right up to the stomach, and think of the journey. Think of what structures you see and involve all those structures. Okay?
Yep.
So that is kind of relevant thing. Then in terms of what you can see, obviously it is a broad discussion and you can talk about it for hours, but for the purpose of exam, mainly in CABG surgery, you're talking about regional wall motion abnormalities, because once they put the bypass on, they want to see the most of the myocardium working, And you can mention to the if you you know how to do an TOE, you can mention to the surgeon which areas are not functioning well, or in other words, not perfusing well. So if there are regional wall motion abnormalities, they can be, you can see valvular pathologies like regurgitation over the walls if you are doing a valvular surgery. And you can talk about the valvular areas, and you can also mention about the gradients, transvalvular gradients, which are relevant for the surgery. I mean, there are so many other things you can mention in terms of if you're just mentioning left ventricular TOE. It itself has lots of things to see and talk about. We can also talk about pericardium and pericardial effusion in a cardiac bypass surgery. Also important in a cardiac bypass surgery, you can mention about after they have connected everything back and before they want to look at air bubbles in the heart as well. So you can look for air bubbles in the heart, right?
Yeah.
Because they want to decompress the heart from all air before connecting everything, because otherwise that can cause embolism, right?
Yeah.
So you can talk about air bubbles, and also you from TOE you can mention the positioning of various intracardiac or intra-aortic devices, right?
Yep.
You can
Confirmation of devices, right?
Yeah, you can mention devices, what they are. Then there are lots of other things which are not probably relevant for your exam. I don't want to go into details of those areas because I don't think your exam is set at that level. You need to have basic knowledge about everything. You don't need to have detailed knowledge of everything.
Yeah, you can use the TOE to assess sizes of the valvulars. How narrow or how large, in order to help the surgeons to choose the correct valve to be replaced.
Yeah, I mean, usually the walls have already been, that all has been set pre-op, because you can't find a valve suddenly intraoperatively in the theater. Right. You should have the correct valve available for the patient before you. That has all been decided by the surgeons who have done all the relevant investigations pre-op. So that thing have be, but you need to have a rapid assessment of the ventricular function. You have to see the regional wall motion abnormalities. We can talk about the aortic AV root or mitral AV aortic wall root. You can talk about the regurgitation through the wall, transvalvular gradients, and presence of air in the heart, right? And pericardium as well, whether there are any problems with the pericardium, right? I think that is enough. There might be more which you can. What are the limitations of TOE?
Limitations. So the view for the vessels, definitely it's related to skills dependent on the practitioner skills, the main limitation. Otherwise, limitations, the vessels are not very seen on the TOE. Sometimes you can use the TOE.
When you talk about vessels, then I'm thinking of aorta, and TOE is very much important for looking at
TOE
aorta.
can be used in the big vessels.
Yeah,
I'm meaning the arteries, the coronary arteries. It's a certain limitation on the TOE, but definitely the large vessels, the aorta, the ascending or descending aorta is a good tool to use to see the.
So So look how you look at it. There's a heart which has been opened. The chest is open, so the coronaries are being perfused. Replaced by the vessels from either internal memory or from the legs. But the question is, the surgeons are directly watching the coronaries, right?
Yeah.
What are your problems with TOE and what are your limitations with TOE? So you're not worried about coronary vessels because they are perfusing, they're replacing them anyway. So from TOE point of view, yes, you are right in a way. Certain vessels are difficult to find, and that is pulmonary artery and pulmonary vein. You cannot assess pulmonary artery and pulmonary vein with very well with TOE. Right? There are limited views with that, and also there are limited views of the apex of the heart, right? With TOE, apex of the heart is a bit difficult, and with TOE, the other problem is you can actually provoke tachycardia and hypertension if your technique is not good, and that's not good for the patient.
Yeah, and sometimes if they already open the surgical manipulation of the heart, it's impeding your view. So the better, the earlier the better. Before the chest is open. Is
and the other question that I asked was, what were the events that are relevant to you as an anesthetist if you are performing a coronary artery bypass surgery? The most important events that are relevant are, number one, induction and laryngoscopy. That has to go smoothly. Number two, when the surgeons do sternotomy, because at that time it's a very intense, painful stimulus, which you should have covered with good pain relief.
Sympathetic is important. We need to cut.
Number third event is aortotomy, when they cannulate the aorta.
The blood pressure should be low.
Yeah. And number four event is when you go on bypass. Right. And number five event is when you come off bypass and reperfuse the heart.
Yeah.
Okay.
Yeah.
Right. Yeah, I think that's it. I'll stop you here. But nevertheless, you're done well.
Yeah.
Well.
Great. Yeah. Thank you anyway for the tips. Important is to manage to present. This is, I think, is important. Start. It's a good tip you offer me. Start with the simple things, and progressively go towards the most
the examiner at your level, EDAC level, is not wanting to know about your advanced knowledge of TOE or etc. That will be additional questions which they will ask. But yes, you are mainly asked about the basic monitoring, some additional monitoring that you need, and key things like temperature, like ACT, glucose monitoring, APG monitoring, just the basic that you have to be good at to pass the exam. Okay?
Yeah, thank you, Dr. Yes, sir.
Thank you. Thank you very much. Bye-bye.
Bye-bye.
I'll hand back to Dr. Danish now.
Okay, Pradeep, you have a lady with COPD, chronic smoker with COPD, who has presented for a surgery. She's due for pneumonectomy, right?
Okay.
Now, can you tell me how will you work up this patient for pneumonectomy? The surgeons have decided to do pneumonectomy on her. They have asked you for your opinion whether she is suitable for pneumonectomy.
Sorry, Dr. Danish, how old she is?
She is 58 years old.
Okay, so I will go ahead with, first of all, I will ask brief history, and then I will do my pre-op assessment with history, examination, and then investigations. And history, I will ask with present current illness, as she is a known case of COPD. So I will ask about what medication she is on, what dose she is taking, and how is the control of her COPD, and how frequent she visits to the hospital for that reason, and when last she visited, and for how severity of the disease. And then I can ask with other comorbidities related to that, any other comorbidities if she have. And then I can ask for any anesthesia, previous anesthesia history. I can ask for the allergy, any allergy to any drug or any food. Then I can ask socioeconomic history also and family history. And then I will ask anesthesia related history, like if she has any previous anesthesia exposure for any reason and how it was, is any problem with that also I can ask. And then I will go for the examination. I will do she is a known COPD, so I will basically will be the interest on the respiratory system, basically to examine her, to auscultate her, how's the chest, and then I can ask, I can see for the CVS also, how's this vitals I can see. Then other system I can have a look, and I will ask airway assessment also, airway examination I can do also. And then I will go for the investigations. So baseline investigation, and then a specific investigation regarding his disease.
What are the baseline investigations?
Baseline, I will ask CBC, coagulation, LFT, UNE, and then I can go for the specific one like a chest X-ray. I will ask ECG. I will ask, and then I can see how is the disease severity. If required, I can ask for the PFT also, because she's going for major surgery, pneumonectomy. So PFT is must. I have to ask when it done last, or I will ask to do. And echocardiography, if possible, I can ask also. And then accordingly, I will go for the surgery according to that result.
Anything else in investigations other than the pulmonary function tests and echocardiography?
Yeah, specifically I can ask for the CPEX also, cardiopulmonary exercise testing.
So what is CPEX?
CPEX actually is a cardiopulmonary exercise testing we can do. We can see the oxygen consumption, VO2, and anaerobic threshold we can see also. And that test can be done on they can monitoring basis. There will be the SpO2 monitoring, there will be the heart rate monitoring, blood pressure monitoring, and they will do some exercise. If some patient who's having this arthritis problem or knee problem, they can do by cycling with the hand also. So they will test how is her exercise and how the oxygen consumption, how is the CO2 production, and how the anaerobic threshold we can see, and then accordingly we will manage like this. Accordingly we can go for the surgery.
So what is the VO2 that you what's the cutoff VO2?
A cutoff VO2 is around that is 15 ml per kg, yeah.
Per minute, yeah.
Per minute.
Yeah. Okay. And what about what are the how does it equate to what like 15 is a number that you get? How does it equate to in terms of climbing stairs or in METs? So if someone is climbing 5 flights of stairs, or compared to someone who climbs only 1 flight of stairs, what will be their VO2s?
Yeah, that MET we can see if it's climbing 1 flight of stairs is around 4 METs. If it is 5, then it's around 6 METs. So if it is 4 METs, is around it will be 13 to 15. I think VO2 will be.
Yeah.
Yeah.
10 mils. Okay. So now you have your CPEX or CPET has suggested that the patient can climb 5 flights of stairs and has a VO2 of greater than 20, right? How else would you ascertain about this patient in terms of risk stratification? How would you know that this patient is likely to have post-operative challenging course and post-operatively in terms of complications and extubation and all that?
Yeah, if VO2 is good more than 20, so risk will be less actually, and I will check other things also. I will check on the spirometry FEV1 ratio also. If it is more than 2 liters, then risk will be mild, not much. And then post-op regarding I can ask for the Heidi backup bed, but she may not require the ICU also, because this VO2 is good and FEV1 is more than 2 liters. So hopefully the things will be fine. The risk will be moderate, I can say, yes.
This is a patient who's suffering from emphysema. This is a COPD patient suffering from quite severe emphysema, and the surgery that is planned is debulking surgery, right?
Yeah.
So then how will you proceed with this particular operation?
Yeah, I will first off I will explain to the patient that what I'm going to do, and she will go for that surgery, and I will use for that double lumen tube. I'm planning to one lung ventilation actually. So that can be done with two methods. Either it can be done with double lumen endotracheal tube, or can be done with bronchial blockers also. But the double lumen is the best choice, and I will go with the left-sided usually chosen for the most of these procedures. And then as she's female, so size I will choose are according this 37 to 39 French. And then I will go with one lung ventilation and isolated the operated one lung, and will ventilate the independent lung.
Which lung, sorry?
That one, with a non-ventilated one will be isolated. Ventilated one will be the ventilated. Yeah.
So how will you position this patient on the table?
Initially, we will position supine. Then after intubation, then will be the lateral position. So lateral position, yeah.
Once you've placed the double lumen tube, how will you confirm the placement?
Yeah, that placement can be confirmed by the visual laryngoscopy, and then further will be confirmed with the this fiber optic bronchoscopy.
Okay. How would you do that?
That we can go with this bronchoscope that will go through the endotracheal tube, and will see the tracheal lumen and bronchial lumen and their position. So tracheal lumen should be above the carina, and bronchial one just below the carina. And then that is that these actually having the different colors also. Bronchial one will be blue one, so we can identify easily actually their position with bronchoscope.
Okay. So now you have started the surgery. As the surgeon has not yet made an incision, you have a drop in saturation. The saturation has dropped to 82%. What do you do at this point?
Yeah, initially what I will do, I will increase the FiO2, and then I will see the tube, any secretions or any blood clot. So I have to do suction of the tube, and then we will see the correct position of the, sometime tube will be displaced. So I will correct the position, and then I will change the ventilative parameters also if it is not improved. And then if ventilative parameter I will change, usually it will improve. If not, then I will give the CPAP to the non-dependent lung. Then I will do the, and finally, if still there's the problem, I can ventilate both the lungs.
Okay. So how long does hypoxic pulmonary vasoconstriction take to set in?
I think, sir, it's around maybe 15 to 20 minutes.
So do you think if the patient is desaturating initially, once the lungs has been isolated, it is likely to improve in the next 10 to 15 minutes as hypoxic pulmonary vasoconstriction sets in?
Yeah, sir. Usually it improved. Yes.
Okay. Okay. What would you do other than the measures that you've mentioned earlier to prevent the hypoxic to make sure that hypoxic pulmonary vasoconstriction sets in properly? What are the things that can affect hypoxic pulmonary vasoconstriction?
That things I should not go as this FiO2 more than 50-60%. If and the thing is saturation 90 will be the 92 will be acceptable, because that will this is actually a protective mechanism, and that will reduce the shunt ratio if it is there hypoxic pulmonary vasoconstriction. And other things is if there are surgeries started, I can ask surgeon to clamp the pulmonary artery. That will also improve that hypoxic pulmonary vasoconstriction.
Okay, so what you've told me is that you'll increase the FiO2. You will check the tube position. You will do the suctioning, and you may give CPAP or a gentle ventilation on the non-dependent lung, or increase CPAP. What else do you think you could do in this case?
I can increase the PEEP also, sir. PEEP can be increased, And then it can be insufflation of the catheter. I can put the catheter to insufflate this non-ventilated lung into the non-ventilated lung. That can be done. And then
so will you increase the PEEP in the dependent lung or the non-dependent lung?
No, on the non-dependent lungs.
Okay. What happens if the PEEP increases in the dependent lung?
It may cause maybe the decrease cardiac output. It may cause a hypotension.
Okay. And other than this, any other things that you would make sure you could check to ascertain that?
Yeah, sir. I can do bronchoscopy also to check that this position of this tube actually is it in the right position, and I can inform the surgeon also that these things going on, so they can hold the surgery. And then finally, I think pulmonary artery clamping and by this one both lung ventilation can be done.
So surgery hasn't started yet. The patient the surgeon hasn't made any incision yet.
Yeah, so these things, I think, sir, what I remember, that can be done before surgery. If it is surgery not yet started, I can position the patient supine also, then I can ventilate the both lungs.
So do you think when the patient is in lateral position, the surgeon hasn't gone in yet, do you think you would want the surgeon to proceed?
No, sir.
Why not? You've informed the senior. You've made the surgeon aware. You've informed the senior. Do you think that by proceeding, the physiology might worsen or might improve?
Might worsen, sir. I have to correct these things first, and then I can say them to go ahead for the surgery.
So if the surgeon opens the pleura, how does the physiology change?
Physiology will change, sir. Then the problem with the patient is on lateral position. So normally the dependent lung is ventilated more and oxygenated more, and there will be the perfusion is more on the dependent lung. But when patient anesthetized in lateral position, so non-dependent lung will be more ventilated and more perfused. So that gravity will change. So that will cause also more will be the hypoxia or hypoperfusion will be there.
So if the pleura in the non-dependent lung is opened, that will worsen the hypoxia, or that will improve the hypoxia?
That may worsen the hypoxia.
Why does it worsen the hypoxia?
Because we are ventilating only one lung, other lung is non-functioning, and then
so this is a pathological. The lung which is non-dependent is the pathological lung. It doesn't have a great reserve anyway, right? If you deflate it, all the shunting will reduce, isn't it?
Yeah. Yes, sir.
So the VQ mismatch will improve.
Yeah. It should improve.
So you want the surgeon to stick a knife into the pleura so that the lung collapses. Right? Not the other way around. Not the other way around.
Yeah. Right.
Okay.
Yeah.
Another thing to consider here is you check the muscle relaxation. Make sure that the muscle check the train of 4. If the patient is not adequately relaxed, that could be the other cause of. Make sure the patient is not hypertensive. Make sure hypertension will worsen the VQ mismatch. So that is the other thing. If you have to give fluids or vasopressors, then give the vasoconstrictors or a bit of fluid.
Okay.
Yeah. Okay. So if the patient is hypertensive at this stage, what would you do? Would you give fluid challenges, or what will be your objective in terms of fluid management?
Fluid challenging, sir. In these cases, actually, we should not give much fluid. Actually, they may worsen this scenario, and they may worsen the hypoxia. So if the patient is hypotension, so we can start the minimum dose of vasopressors like norepinephrine can be started.
Right. Yes, absolutely. So you have to titrate the fluids based on urine output and based on the targeted
mean artery pressure.
Mean artery pressure, and use more of vasoconstrictors.
Yeah.
So who are the patients likely to get post one lung ventilation pulmonary edema?
Post-operative research. Those, I think, if we give intraoperative more fluid, and then there'll be hypervolemia there. And the other thing is this the patient pre-op condition should be also matter. Is it optimized its conditions or not? And then those who have pulmonary hypertension, they are more prone to develop pulmonary edema, I think. These conditions are whatever in my mind. Yeah.
High ventilatory pressures, high volumes of one lung ventilation. Patients with previous alcohol abuse, high sort of high risk patients, ASA3, ASA4 patients, and also depends on the type of resection.
Yes.
But foremost, fluid management is the most important thing.
Yes.
Okay. Okay. So how do you work out what is the that how much resection can be done safely? Is there a formula for that?
Yes, so there is formula, but I couldn't collect actually. Normally there is a 19 segment into the lungs, 10 on the right side, 9 on the left lung.
Yeah.
So whatever resection they will do, so accordingly we will calculate the FEV1 ratio, and then we can allow them to how much they can do actually. And post-op we can calculate also. That formula actually I couldn't collect now.
Okay. Now, when you're talking about the lung segments, bronchopulmonary segments, if the patient aspirates while being on the right side, on the right lateral side, which lateral side? Yeah.
Okay.
Which bronchopulmonary segment is most likely to get the aspiration?
Right lateral, yes, right lateral. So I think posterior one, sir.
Okay. And once the patient is on the left side and getting aspirated, which particular segment is likely to get aspiration?
The apical one.
Okay. Okay. Double check that. I think it's the apical one on the right. I'm not 100% sure, but this is something that has been asked.
Yeah, so there is a mnemonic, some formula there they are given. Yeah. I just forget it. I will check it.
Yeah. It just came to my mind while you were on that. The other thing you would do is you would check the DLCO, the diffusion capacity of these patients.
Yes, DLCO.
Have you come across the three-legged stool approach? Probably in the lecture it might have been mentioned. Three-legged stool approach.
Three-legged stool approach for these patients?
Yeah, a tripod, three-legged stool or tripod, a tripod approach. What are the three things that you would check when you're going for the surgery?
I think FEV1 ratio and FEV1 FEC ratio, DLCO, and if you're in lung capacity, and other thing is I think this cardiopulmonary exercise testing to see the oxygen consumption and anaerobic threshold.
Yeah, I think I don't have it right in front of me, but I think it's divided into three things. One is, of course, your cardiac reserve, your cardiopulmonary reserve. That is quite important, which you test by cardiopulmonary exercise testing.
Yeah.
Okay. Then it's the respiratory mechanics and the respiratory diffusion, which is DLCO and your spirometry, which tells you about that. And the third thing, I think it's the cardiac. I think the third thing is pure cardiac efficiency. How one is the diffusion, one is the actual mechanics of your lung elasticity.
ratio, sir.
Yeah, your elasticity. And diffusion is a separate one, and the third one is the reserve, cardiorespiratory reserve.
Cardiopulmonary exercise testing.
Yeah. Double check that. I think it was definitely there in the FEV1 CPAT and DLCO. That's right. Yes. So that was there in the lecture. There's a very
these things. I think.
There is you can go and check online. There is a very interesting paper from anesthetist in Toronto. I think his name is Springer, who had published this paper in 2000 something, but that's where it has come from. Three-legged stool approach. Three-legged stool approach for pneumonectomies. Okay. Great. That's lovely. Thank you very much. I think you've done quite well in terms of Did you manage to attend the lecture yesterday?
Yeah, sir. I attended. Yes.
Yeah, you can tell because your direction was going. Viva was going in the same direction as though you've done recent revision. But it's good. Carry on the same way. Sound a little bit more confident. Pradeep, you sound
okay.
You don't sound confident, and that puts the examiner on alert whether you are, how sort of sure you are about your answers. If you know the answer, sound convinced in making a statement.
Okay, sir.
Yeah, that's it. I think that is the most important. Yeah.
Formula, can you explain us this formula for segment resection? So formula Dr. Rafiq yesterday explained, but I could get it properly.
So there is this. It depends on the FEV1 that. Let me just open it. Give me 2 seconds. So you have to work out what is the predicted post-operative FEV1. So you work out the pre-operative FEV1 first 1% of the pre-operative FEV1, the percentage of pre-operative V1, and then you multiply it by the percentage of tissue removed. So you work out how many segments they will be removing in that, whether it's a lobectomy or a segmentectomy, or what percentage of tissue will be removed, and you subtract that from 1, right? And the whole thing you would multiply by the FEV1. Let me just share the formula.
Yeah, sir. This is FEV1 multiplied by segment left and then divided by 19.
Yeah. Let me just share it with you on this screen, so you have a little bit. Then I can explain it a little probably.
That is actually production of post-op.
Yeah. So you based on this, how much tissue is to be resected, and subtracting it by 1, you will work out what is going to be the predictive post-operative FEV1. Yeah. So, and it says that usually the right lung can be estimated to contribute 52 to 55%, and the left contributes 45 to 48%. So if you're taking away 1/3 of the right lung, then you can work out that you're taking 1/3 of the 55%. Or if you're taking half of the left lung, one of the 2 lobes, then you're taking away 24%. Yeah, Nitin, you're with me?
Yes, sir. Yeah.
Dr. Pradeep, I think you're at work, is it? I can see your colleagues chatting away in the background.
No, sir, I'm in hospital.
That's what I'm saying. I think you're at work. You can see your nursing staff being very active at work. So you take away that, you work out the fraction of the removed, and then you work out how much is the predictive FEV1. Once you've worked out what is the FEV1, based on that percentage, you will be able to predict whether if it's greater than 40%, the predictive FEV1, then you can extubate the patient in the operating room, making sure that the patient is warm, alert, and pain-free. If the predicted FEV1 is 30 to 40%, then you will, what will govern is what was the pre-operative DLCO and any other associated comorbidities. If the patient does not have problem with the gas exchange, with the membrane perfusion, then you could extubate. And if there were no significant comorbidities, then you can extubate. If the patient has considerable comorbidities, pain relief is not good enough, intraoperatively you've encountered problems, then you consider doing staged weaning and extubation. So you continue weaning those patients in the recovery or in ITU, and then do staged extubation. So get them onto pressure support, then extubate them onto BiPAP, and then basically do a staged extubation. Dr. Nitin,
Yes.
has it made some sense?
Yeah. Yeah, and less than 30 is inoperable, I think. Less than 30% is inoperable.
Yeah, if it's less than 30, then these patients will encounter problems.
Yeah, they will not maintain, so they will be re-intubated.
Yeah, 30 to 40
they will not able to cough, or this reflex will be weak.
Yeah, so you have to make sure that adequate analgesia has been provided to these patients. Normally, where I have worked, paravertebral catheters have been placed, and they're generally placed by the surgeon. When they go inside with the video scope, the surgeon is able to sort of poke the needle in the perivertebral space and see it under direct vision, where the needle is actually creating a space from inside, and create a good space, and they can site sometimes a catheter or sometimes a single high volume block in the perivertebral space. So the good post-operative pain relief is very vital, very important to extubate these patients.
Yes.
Do we have equivalent of VO2 max oxygen uptake with MET and the number of flight stairs? Yes, I think that is the one that I shared just now. I'll just share it again. So yeah, just share the slide with you. Let me hide. So one flight of stairs is less than 10. Now you can work out from flight of stairs how much MET it's equivalent to, and then work out what will be the VO2. Whether it's 5 METs or 6 METs, you work out. I can't remember, to be honest, on top of my head, but based on the flight of stair calculation, you can determine that. Okay.
Yeah,
great.
That is
okay, I think that was great again, Pradeep. It's good going.
Thank you, sir.
Well
Thank
done.
you, Dr. Anish.
You're very welcome. Thank you. Okay, let's have the final session now. Who wants to come up? One flight is 4 METs. Okay. One flight is 4 METs. That's great. Okay, that's fantastic. 1 MET is equal to 3.4 mils per kilogram. That's perfect. See, you got this is the guy who's having an exam in less than 2 weeks. You ask him anything, he'll bring up the details straight away. Great. No, it's a good thing. I'm complimenting you, not pulling your leg. It's this is how it should be. You should be able to bring these details up very quickly. Okay, so who wants to come up next, guys? Nitin, you want to go ahead? I can see you're
yes,
muted.
Yeah. Okay.
Okay. So you have a patient who has who is a 70-year-old lady who's come up with fractured neck of femur.
Okay.
And she is known to have aortic stenosis in the past. And on this occasion, she had a syncope, had a fall. As a result, she broke her femur. How would you proceed, and what more would you like to know in the history?
So I will summarize the patient. She is 70-year-old, and she had severe aortic stenosis. And
Yes.
she had, because of the aortic stenosis, she had a syncope. She had a history of syncope. So I will go for my I will go with this patient as according to preoperative assessment. In preoperative assessment, I will go for, I will check, I will take a history about the patient because she is a known case of aortic stenosis. I will more focus on the cardiovascular history, and she's also old 70 years old, so she must have other comorbidity along with this. So I will also focus on that. So if I will go from the cardiovascular system point of view, so first of all, I will ask her since how long she is suffering and how since how long she is knowing about this her problem, whether she knows this aortic stenosis is there with her or she doesn't know, whether she is contacting with she has she is doing follow with cardiologist or any other cardiac doctor to whether she is doing evaluation for this aortic stenosis, whether they advise for any operative or any interventional procedure for her, and what else? Yeah, and how symptomatic it is first, and then I'll ask her how symptomatic it is, and because it is syncope, so this is severe aortic stenosis, and it is really symptomatic, and I think she has to go. She has to do as early as possible aortic this one. She has to open aortic stenosis either by intervention in cath lab, they can open with the catheter, balloon dilatations, or they can do implant the valve in the cath lab, as well as she has to go for the surgery, aortic valve replacement.
What is that called when they do TAVI? Yeah.
TAVI, yeah. This is transarterial valvular transplantation, aortic valve transplantations. Yeah, and okay, and then clinically, if I will go for clinically, if I'll ask her about the her history, how I will ask for the any complaint of dyspnea, how bad it is, how what is the NYHA grading for the dyspnea? It is more than 3. Is there any paroxysmal nocturnal dyspnea? Is there any orthopnea? And how frequently she has this syncope before? How frequently she is noticing about this problem, syncope? This is first time happen or before also happen? And I will also ask about whether she was investigated for this syncope because maybe some other issue maybe also there CNS related. So whether she did any CT scan or anything before this. And I will also ask for any medication history because she is aortic stenosis. She is taking any cardiac medication for that. She is getting any rate control therapy or other medications, whether she is taking or not. And I will also see for the other comorbidities, whether she has a diabetic, there is whether she is diabetic, whether she is hypertensive, and let's see in history, the other common history like allergic, any operative surgery before she underwent, and I will ask on examinations I will see for all the what do you call there I will see the how her lungs, respiratory system I will go for, how is her lungs on auscultations, and then I will auscultate her heart as well. How is the murmur? And severe aortic stenosis, there is a very good murmur will be there. Means aortic stenosis murmur will be it is systolic murmur you will be finding there.
Where would you feel? Where would you auscultate for it?
It is for aortic stenosis. You have to right rest tunnel, means right second intercostal space, right side.
Okay.
And for,
So it will migrate to that side, is it?
Yeah, and
Or,
I think this aortic stenosis murmur may can migrate up. You can feel the carotid thread as well with aortic stenosis. Severe aortic stenosis is there. And
okay. So
yeah.
this patient is found when you investigate further. She's a hypertensive who's on ACE inhibitors. She had heart failure previously, so she's on digoxin as well. And she had an MI and had a stent placed in, and she's on dual antiplatelets as well for that. How will you proceed for this fracture neck of femur?
Okay, so she is hypertensive. She's already, but she has already aortic stenosis, but she never operated for that.
No, she's never had. Yeah, and
okay,
it's
so
0.6. The
area is, yeah, it is less than 1 centimeter square is a severe aortic stenosis.
Yeah,
so
and the pressure mean gradient is about it's about 50 millimeters of mercury.
Yeah, more than 40 millimeter mercury is severe. It is again, it is very indicating very severe aortic stenosis. So on the top of she has hypertension, and she is on ACE inhibitor. She is on digoxin, and she had a history of MI, and she had a stent as well. So and on dual antiplatelet as well. So right, yeah. So it is very high risk case, and I will always involve my consultant. Now always inform about these patients. Now I will in investigations. I will ask for all the routine investigation and specific investigations for her. So routine investigations, I will do all the CBC, complete blood count, kidney function, urea and creatinine or electrolytes, then liver function test, and blood sugars I will check. Then in specific, I will definitely check for our ECG, chest X-ray, and then echo report, whether when they underwent the echo, last echo, definitely ask for the last echo images and report, and her last consultation with the cardiologist. So these are the specific investigation, and although because she's on LTD platelet, so I will ask also coagulations profile, including APTT, PT, INR, and
so on the ECG, you find that she is having she's an atrial fibrillation, and she gives you no history of any previous atrial fibrillation. How would you manage this?
So this is I think because of the chronic aortic stenosis, her this one she is in systolic, must have a systolic dysfunction. Because of that, she is throwing all the arrhythmias, and this is first time atrial fibrillations. So because severe aortic stenosis plus atrial fibrillation is not very good combinations. Patient will be in there will be very bad hemodynamic at that time. It be blood pressure, and it's I will check for the blood pressures, and if it is very low blood pressure, then I will straight away go with the cardioversion, synchronized cardioversion. But if it's holding blood pressure, I can definitely try with the beta blockers and amiodarone to control the rate.
So now she's due for a hip surgery as well, and you have a choice of about you have to consider about anticoagulation as well. So would you start anticoagulating her straight away, or would you go for the surgery and take the chance about anticoagulation after 24 or 48 hours?
So I will discuss with the surgeons, the orthopedic surgeon, how urgent it is, the procedure. And if it is urgent procedure, then I will definitely stop this because now I will not have any time to stop the antiplatelet, because it's dual antiplatelet. I need at least 72 hours to stop the this. This is aspirin and Plavix, both.
Yeah, clopidogrel and
yeah. So for clopidogrel, minimum requirement time is usually 5 days before any surgery. But in this emergency surgery, if it is emergency surgery, then I think I have to take the consent with the patient, explain about the risk or bleeding and everything, and then I can go with the general anesthesia.
So this anticoagulation that I'm mentioning about, the ones that she's on are dual antiplatelets.
Yeah.
The anticoagulation that I've just mentioned is for new onset atrial fibrillation, so that the thrombus is not formed. How soon are you expected to? How soon should you be putting the patient on warfarin or any anticoagulation once for a new onset atrial fibrillation? And what should you make sure before you put the patient on anticoagulation? I'm briefly turning the video off. You can please answer.
Yeah. So she's new onset atrial fibrillation right now, and she has a the question is what I will consider before starting anticoagulant. What I will. Hello?
Can you hear me?
Yeah, I can hear you now.
Yes. Sorry. The question is that this lady has a new onset atrial fibrillation, which needs for which she needs to, of course, anticoagulant has to be started. It has to be started. So it has to be started within the what time frame, and what are the preconditions? What are the things that you need to ascertain before you start her on or what are the things that you need to do before you start anticoagulation? Or if she was hypertensive and you were to cardiovert her, what are the other preconditions before cardioverting her? Before electrically cardioverting?
Yeah, so I definitely I will check all the investigation, and especially all the electrolyte correction is there. Potassium is very important, potassium, magnesium. And I will correct the electrolyte this one before going for the cardioversion. Second, the most important thing is to check the echo and see the any clot is there, because we don't. Because unnoticed atrial fibrillation will be there in previously we don't know. So there will be thrombus, will be there, and it's made emboli anytime. So we have to check for the embolus as well as the electrolyte imbalance, and then.
Very good.
And then we can go ahead with the about this anticoagulant, as you told. before starting anticoagulant, what?
So you have done the right thing. You've involved the surgeon, and you have checked with the surgeon whether the surgery needs to go ahead. And as you rightly said, if it's an urgent surgery, you would go ahead with the surgery, and 24 to 48 hours post-operatively, you will start the anticoagulation. Because if you go ahead with the anticoagulation, the surgery could be deferred for a couple more days, and neck of femur, you cannot afford to keep the patient immobile with and in pain. You're looking for more problems as a result.
So after post-op, you can start heparin or
yes, you will start with the exactly. You start with shorter acting drugs, unfractionated heparin first, which can be reversed quickly. Once that initial period where post-operative bleeding has overcome, then you start the patient after a couple of days, 5 to 7 days, maybe a week or so, on warfarin or any other anticoagulants.
Okay.
Yeah.
Yeah.
How do you calculate pressure gradient using an echo? What is the principle behind it?
On echo.
On transthoracic echo or on any echo, how do you work out the pressure gradient? How does it tell you the reading of pressure gradient?
It is Bernoulli equation. It is Bernoulli equation. It's going.
Yeah. So you work out the flow. Your flow is measured, right?
Yeah.
And based on the flow, how do you work out the pressure difference?
The flow. I'm not able to recollect. I read, but I forgot.
That's fine. That's fine. There's a law of conversion of mass. So, yeah, it's that the area times velocity is constant. That equation you use. So, area of LVOT times velocity in LVOT is equal to the area of valve, aortic valve, times the velocity at the valve, and that's how you work out what is the aortic valve area.
Okay.
I think that's pretty much it. Actually, you've answered everything in that. The scenario was we tried to build it up, with the clinical situations that you come across in your daily practice. When do you anticoagulate a patient with atrial fibrillation? Should you do, if the patient has presented with trauma, should you be starting anticoagulation straight away, or you do rate control, optimize the condition while the patient is having surgery, and then post-operatively you start anticoagulation? So these are the kind of clinical decisions that they might ask you to. They might see what's your critical thinking. How are you able to arrive at a plan? And as you rightly said, you work when the situation is complex. You get the surgeons involved. You get all the parties involved. Make sure that the surgeon, the cardiologist, everybody's involved, and it's a joint decision making rather than taking the burden of responsibility on yourself. Make sure that you take opinion. Involving your senior is very important, as you rightly did. But whenever you get such a situation, they may not want you to have a full answer, but as long as you're able to get the team together and make some recommendation, as you rightly said, that yes, I will optimize the cardiac functions. I will make sure what the echo is showing. I will not do the cardioversion because there could be a possibility of thrombus. So these are the right things that you're saying for them to feel confident that you can manage this clinical scenario. So this particular scenario will test not just your knowledge, but your understanding of the safety in that situation. Are you a safe person? Are your decisions safe for the patient? So that is what probably the examiner would be probing you into.
Okay.
Fractured neck of femur, it is something that has to be done as soon as possible, unless there are 3 or 4 things. Unless it's a palliative procedure, if it's just done for pain, someone who's got a pathological fracture of femur and cannot be corrected, then you just put them on good analgesia, put a block or something, or a catheter to give them good analgesia, and just not intervene at that point. So and second thing is, if there is any other significant reason why you should not be operating on the patient, like severe anticoagulation, patient has been on irreversible anticoagulant, you have to wait for that. Surgery is not possible. Infection,
even for block also we have to wait for the, I think Plavix is okay.
Yes.
We can block with Plavix. With clopidogrel.
With clopidogrel you can do a block. Yes. Neuraxial blockade is neuraxial blockade is an issue, but not. I don't think the block should be a problem, especially when you're nicely ruling out all the vascular sort of vessels around it. You don't want to do a block blindly without being aware of the vessels, even the smaller vessels around the nerves.
Oh
yeah.
Especially peripheral block, I think we can go ahead.
Peripheral block, yes, certainly. Not brachial plexus block, I wouldn't probably consider, or lumbar plexus block, but femoral block shouldn't be a problem. You scan the vessels properly and do a femoral block. Yeah.
Okay.
Great. So that was some part of the cardiac. I think. I don't know what we will ask. I'll go through some other cardiac questions, and maybe a little bit more about valvular conditions, more about tamponade, how to manage tamponade. Those are the kind of questions. Some images of echo, and to identify, to see the difference between cardiac tamponade and pleural effusion. That is something you need to know as well. Yeah, those are the other things that we can discuss, and maybe more of clinical scenarios with cardiac patient, pregnant lady with with cardiac condition. Yeah.
I have one question about this. Actually, when we are going for the surgery, she's already on ACE inhibitor and digoxin. So ACE inhibitor we are usually avoiding. Do we stop digoxin as well, or we continue?
No, you have to continue, because that's with the rate control, and it will not impact your surgery or hypertension. It should not make any difference. You have to do, as you rightly said, you have to do electrolyte check. You have to make sure the patient is optimized electrolyte wise, but you have to continue with the digoxin.
Okay.
Yeah.
Thank you.
Lovely. That's great. Thank you very much, guys, for today's session. I think time flies as you start going through these scenarios. I hope you enjoyed. I'd rather like more people to participate in these sessions, because you learn when you are in the forefront. You still have a lot of time before your exam, so feel free to come forward and volunteer. No one is perfect. I mean, to be honest, I feel sometimes like a fool when I'm asking these questions, because I do not know enough about them. I'm just reading and asking you. So don't feel that you will be judged or anything like that. It's we're all learning in this journey. No one is perfect. We learn as much as you do by reading just before asking you those questions. So it's all about how we all can sort of gain knowledge and feel ourselves sort of really ready for this exam. And believe me, the more you face these vivas, the more your inhibition will go away, and you'll feel more able to speak up on the day. So start the volunteering as soon as you can. It will really help you immensely for the exam. Okay, what will be the Viva topic for next Friday? So we just discussed about maybe some more valvular lesions, a little bit about cardiac tamponade, little bit more about thoracic surgeries, and maybe in a few other scenarios in thoracic surgeries, and non-cardiac surgery on a cardiac patient. Some scenarios of that, and maybe a few other drugs related to heart, and I think that should be enough. Maybe if you want, we can revise a little bit more on the physiology side, just to make sure you guys are up to date. That is another thing we can do. Yeah. Fantastic. So I'll see you guys on Friday again. And until then, you have a good week, and don't study too hard. Take care and good night.
Formula.